Welcome to Pulse&Pressors, where critical care gets crystal clear. Today, we dissect the surgical repair of type A aortic aneurysms, comparing three major approaches: the Bentall, the valve-sparing root replacement, and the supercoronary tube graft. We'll connect operative anatomy, ICU priorities, and long-term protection, the full continuum of care. A type A aortic aneurysm involves the ascending aorta, often extending to the root, annulus, or sinotubular junction. These structures define the operation. The annulus anchors the valve leaflets, the sinuses of Valsalva create eddy flow for valve closure, and the STJ transitions into the ascending aorta. When dilation compromises these zones, root replacement becomes mandatory to prevent rupture, tamponade, or dissection. The Bentall is the most comprehensive repair. The aortic root, ascending aorta, and valve are replaced with a single composite graft. The coronary arteries are detached and re-implanted into the graft wall, restoring perfusion. This procedure eliminates all diseased tissue, but creates a lifelong dependency on a prosthetic valve and, if mechanical, on anticoagulation. When the aortic valve is structurally sound, surgeons may spare it. In the David procedure, the entire valve apparatus is excised and re-implanted inside a Dacron graft, securing the annulus and preventing future dilation, ideal for connective tissue disorders. In the Yacoub method, the root is remodeled and the sinuses reconstructed to mimic natural flow at the STJ, preserving physiologic motion, but with slightly less annular stability. Both techniques avoid prosthetic valve replacement and eliminate lifelong warfarin, a major lifestyle benefit. When the aneurysm is confined to the ascending aorta above the coronaries, the repair can be simplified to a supracoronary tube graft. The valve and root remain untouched, and the diseased segment alone is replaced. It's the least complex form of type A repair, offering durability with minimal disruption of native anatomy. Not every patient qualifies for valve-sparing surgery. If the valve is severely calcified, torn, or bicuspid with non-coapting leaflets, a Bentall provides definitive correction. For extreme annular dilation in connective tissue disease, the David technique can be used, but when stability is paramount, surgeons favor a Bentall. A supracoronary tube graft is ideal if the valve and root are normal. And most importantly, an intra-aortic balloon pump is absolutely contraindicated in any patient with a root or ascending graft. The balloon's mechanical pulsation can disrupt the new suture lines, causing catastrophic graft rupture or bleeding. The Bentall offers permanent stability but depends on prosthetics. Valve-sparing approaches retain natural function, but require surgical mastery and are reserved for optimal anatomy. The David procedure's annular stabilization is especially valuable in Marfan and Loeys-Dietz syndromes, while the Yacoub approach offers more physiologic root dynamics. In both, the sinotubular junction is reconstructed precisely to restore natural flow geometry. In Bentall patients, valve type determines long-term management. Mechanical valves last indefinitely, but require lifelong warfarin, with all the vigilance, monitoring, and bleeding risk that entails. Biologic valves eliminate anticoagulation, but typically wear out after 10 to 20 years. For younger patients, durability often wins. For older or anticoagulation-intolerant patients, tissue valves offer a simpler life. Post-operatively, tight blood pressure control is the single most important determinant of survival. Systolic pressure should remain below 110 to 120 millimeters of mercury and MAP between 65 to 75. Overnight intubation allows continuous sedation and minute-to-minute titration using esmolol or clevidipine. Hypertension or tachycardia can rupture the anastomosis or propagate dissection. Sinus rhythm with a slow, regular rate protects both graft and myocardium. In the ICU, continuous Swan-Ganz monitoring provides preload, afterload, and cardiac output trends. Monitor for low output, tamponade, or coronary re-implant ischemia. Control pain and agitation aggressively. Even one hypertensive cough can undo the repair. Communicate the balloon pump contraindication clearly during handoffs and documentation. Extubate only when blood pressure and rhythm are consistently stable. After discharge, lifelong blood pressure control with a beta blocker, or ARB, is essential. Follow-up imaging, CT or MRI, at 6 months, then annually, ensures graft and root integrity. Mechanical valves require lifelong anticoagulation. Valve-sparing repairs rely on surveillance. Routine echocardiography monitors the annulus, sinotubular junction, and valve motion. Patient education is the best prophylaxis. An informed patient preserves the repair. The Bentall, valve-sparing, and supercoronary graft all restore life and stability after catastrophic aortic disease. Each has its indication and its physiology. In the end, success depends on teamwork, surgical precision, ICU vigilance, and lifelong discipline. Because when patients understand their valve, they protect it. This is Pulse&Pressors, reflecting on the marvels of the human body. Subscribe to stay sharp.